Hello, I'm Dr. Ira Nash. Welcome to Well Said. Ever felt like you had a lump in your throat that just wouldn't go away, or a weird cough that lingers no matter what you do? You might chalk it up to allergies or stress. It may be something you've never heard of, laryngeal-pharyngeal reflux. It's like acid reflux's sneaky cousin, showing up without the heartburn, but with symptoms that can confuse both patients and doctors. Today we're breaking down what that is, why it happens, and how to stop it from hijacking your throat and your voice. To help us unpack this, I'm happy to be joined by Dr. Seth Kaplan. Dr. Kaplan is a fellowship-trained laryngologist and serves as the director of the Center for Voice and Swallowing Disorders at Lenox Hill and Manhattan Eye, Ear, and Throat Hospitals. He's also an assistant professor in the Department of Otolaryngology and Head and Neck Surgery at the Zucker School of Medicine. Seth, welcome to Well Said.
Thank you for having me.
All right, so I almost got out the name of this that we're talking about without stumbling on it. Laryngeal-pharyngeal reflux.
If you'd like to call it LPR for the rest,
please,
it makes
yes,
it a lot
let's
easier.
just call it LPR. Thank you so much.
Yeah.
So what is it?
What LPR is when acid and stomach contents come up through the stomach channels, through the esophagus, and up to the throat. And then it has an effect on the throat.
I'm sure our listeners are familiar, or maybe more familiar, with what we commonly call acid reflux or gastroesophageal reflux disease, or GERD. How is this LPR different from the garden variety acid reflux that people may experience as heartburn, take a Tums, gets better?
So they are very similar, but the difference is that the acid actually continues up the esophagus and into the throat. Patients will experience a lot of throat-related issues, including voice changes, sensations in their throat, irritation in their throat, amongst other things. And sometimes they don't experience heartburn or pain in their chest. So that's why it's also called silent reflux, and that's why it gets that moniker as well.
So remind us a little bit of the anatomy here. So we're talking about the esophagus, the throat. Give us a little roadmap so we have a clearer sense, or our listeners have a clearer sense of how things are connected and where this is happening.
So when you're chewing food or swallowing food, it starts in your mouth, it goes to your throat, and then it passes through to the esophagus. Now, between the throat and the esophagus is a muscle. It's actually a sphincter-type muscle called the cricopharyngeus, and for that we can call it the CP muscle.
Yes, please.
That muscle protects things coming from the esophagus up to the throat. When food passes into the esophagus, then you have a sphincter between the esophagus and the stomach.
Okay, before we get to the stomach, the CP also prevents your food from going into your lungs, right?
I wouldn't entirely say it that way.
Okay.
I think that the things that protect food from going into our lungs is actually our vocal cords and our larynx. That's why, for example, if you've ever had a sip of water go down, I'm air quoting here, the wrong way, and you go into laryngospasm, meaning you start coughing and choking, that's actually your vocal cords that shut closed to protect your airway.
Oh, okay. In the normal scheme of things, the airway is in front of the esophagus, the food tube, right? So food goes from the mouth past the opening where the air goes in and out.
Exactly.
And then down into the stomach. And you were saying there's sort of two control valves.
The top sphincter, basically between the throat and the esophagus, that's the CP muscle.
Okay.
And that actually sits in a contracted position most of the time. And when you're swallowing, that's when it relaxes, opens up, and allows food to pass into the esophagus.
Okay. And then where's the other sphincter?
So then food is brought down the esophagus through peristalsis. It's like a wave-like motion along the esophagus, down past a lower sphincter, and that sphincter is between the esophagus and the stomach.
Why is that important?
Because that's another barrier that stops things from coming back up.
And the reason why it's important to prevent stuff from coming back up, obviously we want things to just go in the right direction, but the stomach is highly acidic.
Exactly. So the job of the stomach is to dissolve all that food and then start the absorption process. So we have a lot of things that are excreted in the stomach, which create a very acidic environment, which helps break down these foods so that they can be digested and absorbed later on in the gastrointestinal tract.
Okay, so the stomach is kind of this acid bath for our food. These sphincters prevent that acid from going back up.
Exactly.
Okay. In the sort of garden variety, I'll call it, acid reflux, people tend to have pretty intense, or can have pretty intense, sensations of discomfort in the chest associated with that acid and stomach contents coming back up. Why don't they feel that in LPR?
So that's an interesting question. I don't know if we can fully answer that, but I'm guessing that it has mostly to do with acid concentration, where it's hitting where it's causing erosive changes or irritation to the linings in different areas. So if there are repeated areas, there are plenty of people who do have heartburn as well as LPR, but there's just a lower percentage of people who have that, which is why sometimes it's silent and it's only affecting the throat.
Okay. And so it's silent. When you say it's silent because they don't have the typical heartburn.
That's exactly right.
And sort of dyspepsia so that we associate with acid reflux. But it's not silent in the fact that it is causing other problems.
Yeah, absolutely.
So talk us through what some of those other problems are. What do people complain of that leads you to a diagnosis of LPR?
There's a variety of throat-related symptoms that people complain of. Sometimes people come into my clinic complaining of a tightness in their throat, a sensation that something's in their throat, a tickle, a golf ball sensation, something obstructing their swallowing, when there's actually no problem with food passing into the esophagus. A lot of the times patients complain with voice-related issues. Sometimes they'll even have pain in their throat, or sometimes like literally pinpoint pain. They could say, literally use their index finger, point to their neck and say, it hurts right here. And that's an indication of some of the sequela from reflux or acid getting into the throat.
And you said this can sometimes affect the voice. What kind of impact does it have there?
As you noted before, the swallowing and the airway and the vocal cords are very close together.
Yeah.
And so when the acid comes up into the throat, it starts affecting the organ of the throat, which is the larynx. Typically...
So the larynx is the voice box.
That's the voice box.
All right. So that's where the vocal cords are, and they vibrate and create the
phonation and sound that we make. It's also the area that we breathe through. What happens is when acid gets up into these areas, it can cause irritation, swelling, redness. Sometimes it can create something called granulomas. These are small areas of healing and overhealing tissue on the vocal folds. Those are the things that can cause that pinpoint pain. And that swelling sensation does make people feel like there's actually something there stuck in their throat.
How common is this?
It's fairly common. 10% of all ENT visits usually end up with a diagnosis of LPR in some form or another.
Those are people who find their way to an ear, nose, and throat specialist.
Exactly.
But in kind of the general population, I mean, is this pretty common occurrence?
Absolutely. I think millions of Americans have these types of symptoms. Many times they actually go undiagnosed. People don't actually present to an ENT.
Is there a typical profile of somebody who has this?
I wouldn't say there's a typical profile. A lot of different people can have these issues, but there are some underlying factors that can lead to patients having excessive reflux. One is obesity. A lot of people with obesity have loosening of those sphincters and allow for acid to come up. There's also more abdominal pressure, which helps acid come up as well. Smokers certainly get this. People who use alcohol, pregnant women, a lot of the hormones of pregnancy actually relax these sphincters, plus the abdominal pressure as well will allow for reflux to come up to the throat. So those are some of the underlying reasons why people have this. But the other one is patients' diets. That's a major factor. And so when people like spicy foods and other foods that lead to excessive acid production, or foods that in particular relax the sphincters and get rid of that protective barrier, those are the patients that we see.
Which are those foods that relax
so that
the
is,
sphincters?
Yeah, that
all
is
the things that
classic
people
things.
love to
That's
eat.
exactly
keep
right.
going.
So these are the classic questions that patients are asking about all of the time. So the main ones that I review with patients, and I ask them, are these a major part of your diet or not? Coffee, mint or peppermint, chocolate, carbonated beverages, tomatoes, garlic, onion, blueberries, citrus. So I always say grapefruit, orange, pineapple, lemon. Those are the main factors. And some of those I've learned on the way of treating patients as well. I've had patients who have these symptoms. They drink a blueberry shake every morning. I said, cut that out, and they got better. And that's one of the sad things about it, because blueberries, for example, is one of these superfoods with lots of antioxidants.
You, right?
A lot of fruits and vegetables, which are very healthy for you, are bad for acid reflux. So it's a tough thing. So I always tell people, I'm not putting you on a low-fat diet, although high-fat diets can also lead to reflux, but this is not a weight loss diet. This is a low acid diet.
Okay.
The other things, just the foods, but I always ask people if they're eating late at night or close to bedtime. I ask about how much water intake they have. Those things can help neutralize things in the stomach and help with your swallowing. Those are the main things that I'll ask patients about.
So I understand some of the things you mentioned. I can sort of conjure up a reason why spicy food stimulates more action in the stomach and more acid production. I'm scratching my head a little bit for some of these, like why carbonated beverages?
What carbonated beverages do, all those bubbles that are sitting in your stomach, that increases pressure, and that pressure works on that lower sphincter between the esophagus and the stomach. And those bubbles allow it to open just a little bit more and allows acidic contents to get into the esophagus, which then would travel upwards. Some of the other foods, they don't actually produce more acid. So for example, chocolate, alcohol, mint, those are also working to relax the lower sphincter.
Directly.
Exactly. And so those weaken that muscle, which allows acid to come up versus actually creating more acid in the stomach.
I think you mentioned coffee too.
Coffee, I will say, is one of the more debatable ones. A lot of people who study this go back and forth on this. And where I land with patients is I say, it's okay, you can take, a cup of coffee if it's really going to create a big issue for you. At the same time, when I'm treating patients for this, I typically start them on anti-reflux medications as well. So I tell my patients, listen, you got to live your life. You got to do the best that you can. And so I think that the medications do a good job of helping along that process, but it's a very difficult thing to do.
Well, you just mentioned cutting out a lot of stuff. I imagine that's a big hurdle to get over. We'll come back to that in a second, but I want to ask you a couple more questions about the things that you said can stimulate this or worsen it. Alcohol? What's the story there?
So alcohol acts as a muscle relaxant in a way. It relaxes that muscle so it's not as tightly clenched or closed. That's what allows acid to come up. That also has an effect on the esophagus and how things are, the peristalsis or that waveform come down again. That's typically what alcohol will do.
And what about smoking? You mentioned smoking.
Smoking, absolutely. Same thing.
That so can direct effect on
direct effect, plus the effect of smoking in itself. If you even have one puff of a cigarette, it paralyzes all of the cilia from your nose to your throat. And so what are cilia? If you remember back to 7th grade biology, cilia are basically those hair-like projections that pulsate. And those are the things that carry things out of your nose, for example. That's the thing that gets the snot out of your nose, whether it's out of the front of your nose, at the back. It's the things that get things moving on a microscopic level. And so when those aren't working as well, things don't move as well. And so you can get this buildup of mucus and other things. In terms of reflux, it can cause irritation. And if those irritations are happening in your throat and then you hit it with acid, it makes it much worse. But it also has an effect on the actual movement in your throat and how things are carried down to your stomach as well.
You mentioned a whole bunch of foods and sort of conditions, obesity, pregnancy, that can affect this. Is there a genetic component to this or an environmental component that is known?
That's a tougher one to say. I've not really come across a genetic or environmental component specifically for reflux.
Speaking to friends, colleagues, peers, some people seem to kind of develop this pretty rapidly. They're fine, and then they get what they think is a cold or an upper respiratory infection. They sort of bounce around a couple of doctors, and then they get a diagnosis of LPR. Is that your observation as well, or does this tend to be a more insidious onset in most people?
I would say it's mostly more insidious. Now, in the example of someone with an upper respiratory infection, they might have these symptoms of an upper respiratory infection. They might get sick, and that might be what brings them to an ear, nose, and throat doctor's office. But then on further exam, that might be something else that is discovered at that time. But I wouldn't say that an upper respiratory infection brings that on or makes it worse. Typically, it is insidious. Listen, as we get older, people gain weight, their metabolism changes. The things that they were once eating affects them a little bit differently now. So that's typically what happens, because this is really something that happens over time. It's really due to chronic inflammation in the throat. It's really not a one-time thing where you had one meal, a lot of reflux, and then you have LPR. Okay. It's really more chronic than that.
And so for those people who may be listening and have, a little tickle in their throat or a cough every once in a while, is there some sort of intensity or constellation of symptoms that you would say, that's worthy of getting evaluated as opposed to, don't worry about it?
So as an ENT, I would say that if you are having 2 to 3 weeks of throat-related symptoms that are not going away, you should be seen by an ear, nose, and throat doctor. If there is a throat issue that feels like there is chronic mucus, irritation, pain, changes in your voice that does not go away or is not improving by 3 weeks, you should see an ear, nose, and throat doctor and get a laryngoscopy.
Okay, so that brings me to the next question. So somebody has these symptoms, maybe they've spoken to their primary care doctor, made a referral to an ENT, or they find their way to somebody like you. What do you do to evaluate that patient and make a diagnosis of LPR?
When someone comes into my practice, the first thing I do is take a really good history. That gives me a lot of information. I start generating my differential just by listening to the story that patients are telling me. Then I'm already listening to their voice as they're talking to me.
Okay.
They don't realize that, but I'm already evaluating
You're
what
examining
the difference
their
is.
voice while they're talking.
Exactly.
Yeah.
For our physical exam, the tool that we use the most is laryngoscopy. Laryngoscopy is essentially a tiny camera. It looks like a piece of spaghetti with a camera on the end. And we go through the nose after we numb you, and then we are able to take a look at the throat. And then there are particular findings that we see in the pharynx, meaning your throat, as well as the larynx, that would lead us to believe that you might have these types of changes, especially combined with a history. Now, as a voice specialist, the other thing that I do is something called video stroboscopy. It's very similar to laryngoscopy, except at the end of my laryngoscopic exam, what I do is I'm able to assess the movement of the vocal folds and actually the waveform using a strobe light. And it gives me a lot of information on...
So you're seeing how the vocal cords vibrate?
Exactly.
Huh.
It tells me if, generally speaking, if there's cysts, polyps, nodules, anything along those lines. But it gives me a good indication if there's swelling and redness of the vocal folds as well as it relates to reflux.
So mostly what you're looking for is signs of damage caused by acid?
Exactly.
So irritation, scarring, what other things you're looking for?
Exactly, all of those things. There's a lot of different areas of the larynx that I'm looking at. So edema, which means swelling, I'm looking for those types of findings in particular areas of the larynx or the voice box. I'm looking for erythema, which means redness. Sometimes when reflux is chronic, it can even go beyond the vocal folds and get underneath them and into the trachea, the windpipe, and that can cause swelling there as well. There have been cases of subglottic stenosis or narrowing of the airway from chronic reflux as well.
Wow, so just from that acid kind of causing irritation, scarring, and then the tightening down of the tissues. I guess that sort of answers my next question, which was going to be whether this is really something that's dangerous or just bothersome.
For the vast majority of patients, it's more bothersome. It's about symptom control. But yes, reflux has been shown to create a lot of dangerous situations in patients, specifically what we were talking about, subglottic stenosis. It can make that worse. Certainly in our cancer patients with head and neck cancer, we see that there have been increased rates of reflux in those patients. It's just chronic irritation to the lining of the throat and the larynx and the esophagus, which can basically create a lot of damage in cells, which can then ultimately lead to cancers.
So this is not something that's just about making people feel better. I mean, you're trying to prevent some downstream bad event, even though it may actually be pretty uncommon.
Yeah, for sure. It is uncommon, but we do see it. It's good to have that early intervention and make sure that we're taking care of it as quickly as possible.
Somebody's had these symptoms. They've had them for long enough that they seek medical attention. They come to an expert like you. You stick the camera down their throat. You make the diagnosis. Now what?
Okay, so then we start talking about treatment. Now, there's a couple of different things that we do for treatments. The classic thing is medication. So there are essentially two anti-reflux medications that we use. One is PPIs, also known as proton pump inhibitors.
So those diminish the amount of acid production in the stomach.
Exactly. They work on those receptors that release acidic products into the stomach directly. So those are your classic omeprazole, pantoprazole. You've probably heard of a lot of these things. The brand names are like Prilosec. And then the other medication that we use is H2 blockers, which have a similar mechanism. They typically work a little bit better at nighttime and before bed.
So those also reduce stomach acid.
Exactly.
So give an example, a name of a drug that falls into that class.
Famotidine.
Okay.
Yep, or Pepsid.
Okay. So two different medicines designed to kind of do the same thing by different mechanisms, reduce that amount of stomach acid.
Exactly. I use the PPIs in the morning, which carry patients throughout the day, and then the H2 blockers at nighttime before they go to bed.
Is there anything that you do that directly affects that sphincter, that muscle that separates the stomach from the esophagus?
Again, we go into food avoidance. So the particular foods that could be causing those issues, that's what we would ask patients to avoid. And it's not just those foods, but a lot of the foods that we had already mentioned.
Yeah.
So it's really what we call diet behavior modification. Those are the main treatments. It goes beyond just food avoidance as well. For example, a lot of patients will have reflux when they're laying supine, meaning on their back facing up. And that's because when you're doing that, it's a lot easier for acid to go from the stomach up to the throat. You don't have the help of gravity when you're walking around.
Sure.
So we have patients use wedge pillows. I actually did some research when I did my fellowship at Cleveland Clinic on patients who were refractory to the medications, meaning it didn't work. There's a special pillow that keeps you on a wedge. It means you're elevated. Your head and your shoulders are above your stomach, and you're also on your left side. That is because your anatomy, the way that your stomach sits on that left side, if you lay with your left side down and on a wedge, then you're really using gravity to prevent acid from getting up to your throat.
So it just keeps all that stuff in the stomach.
Exactly.
More so than it would if you were on your right side or laying flat.
Exactly.
Yeah.
There's also a new class of treatments that I've been recommending to patients, and these are alginates. Alginates are really kind of a fascinating topic because I think it's gaining popularity in the United States. It's used much more widely in Europe. It's exactly that. It's algae. It's safe. It's effective. It has minimal side effects.
And what does that do?
You take it about a teaspoon to a tablespoon after meals and before bedtime. And when you swallow it, it basically goes down to the stomach and creates this layer on top of the stomach contents so that things don't come up into the esophagus.
I want to ask you about the long-term use of some of these acid reduction medications. I mean, we have an acidic stomach for a reason, right? It helps sterilize the food that we eat, and it helps to break down the food that we eat. Are there hazards associated with being on potent acid blockers for an extended period of time?
Definitely. Yeah. PPIs have been shown to have some side effects and long-term complications. Typically, these sound like some scary complications, but it's early onset dementia, kidney disease, and osteoporosis, especially in older women.
Sounds great.
Exactly. I tell my patients all the time, I don't want you on these medications long term. Although patients have, at least in my practice, some have been on this for 10, 20 years and have not had any of these side effects. Typically, my treatment regimen is for 3 months of both of the medications as well as dietary changes. And then I'll reassess patients. If they're 80% better in terms of improvement, I consider that cure. And then I start taking them off of those medications and wean them from them. If you stop cold turkey, you can get some rebound reflux, but I'll slowly take patients off of that. If their symptoms are persisting despite that, then I might do some different treatments or even refer to my GI colleagues for an endoscopy or to look into some other reasons why they might not be getting better.
You mentioned 3 months. Is that how long it typically takes for people to get better, even if they're pretty careful about their dietary changes, they're taking these medications, it just takes time?
Definitely. Just like how we said it's an insidious onset, it's slow to get better. I tell patients all the time, you're not going to get better tomorrow. You're not going to get better next week. There's a reason why I say come back in 3 months. If you follow that, it takes a long time. And the other thing about this is that even though you might feel better, the actual physical exam findings, the swelling, that takes even longer to get better. So patients might come back and say, you know what, I'm feeling a lot better. All those sensations and symptoms have gone away. And I might look and it still might look swollen and red. But we basically go by symptoms in this scenario. Unless there's a more scary physical exam finding, at that point, I would say you're good, stick with the diet, and then after a couple months, reintroduce more acidic foods back into the diet, but only really come back and see me if the symptoms come back.
Yeah, so I want to go back to the dietary changes. So are you talking about lifelong prohibitions against alcohol, chocolate, yada, 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 yada?
So I always tell patients the best you can. I'll speak personally.
Yeah.
If I have red wine, that's the thing that affects me. If I have that at dinner, I know I'm going to have reflux at nighttime. And so I tell patients, if you know that that's going to be your trigger, then yes, you got to cut that out. Now, if you know that you want to do that, then take an anti-reflux medication at that time or try the alginates. Like I said, I tell people, live your life. If you're going to go to an Italian restaurant and have a red sauce type meal, yes, you should be doing these things. And if it's persisting and getting worse, we might need to go back to this long term.
But it sounds like the long-term strategy that you would prefer to see is lifestyle changes, dietary modifications, and sort of episodic use of things that suppress stomach acid, but not chronic use forever and ever of some of these acid-suppressing medications.
We certainly try our best. Like I said, if patients are still symptomatic, at that point, I'll typically send to my GI colleagues, make sure there's not an underlying reason why this might be happening. They're typically more inclined to go higher on doses with longer doses of these medications. There's also other issues that might arise. You might have H. pylori, which is a bacteria in the stomach that predisposes you to having acid reflux. That might be a very easier fix. You can go on antibiotics for 3 weeks and take care of those issues.
Yeah, certainly easier than giving up chocolate for the rest of your life.
Exactly.
Right? Okay.
Yeah.
Are there places that you would recommend our listeners or patients go to get more information about this? They've heard you explain all of this, but they have more questions. Where should they go?
I think that online at the major hospital systems, they'll usually have some pretty good information, like Mayo Clinic or Cleveland Clinic. They have some very good information on LPR. There are 2 books out there. So the person who coined the term LPR is Dr. Jamie Kaufman, and she has a book called Dropping Acid. And the first half of it talks a lot about what we just talked about today, but the second half is a cookbook, and it has recipes for low acid diets. And then there's Dr. Jonathan Aviv. He has a book called The Acid Watcher's Diet. Very similar. The first parts talk about dietary and lifestyle changes. His is more of a 30-day plan to reduce acid, and there's lots of recipes also.
Great. Okay. Final words? Anything else you want to add?
If this is a chronic and persistent issue, make sure you go see your otolaryngologist. Make sure you get checked out and don't let these things continue and fester.
Okay. Well, thank you so much. My guest has been Dr. Seth Kaplan. He is a fellowship-trained laryngologist and the director of the Center for Voice and Swallowing Disorders at Lenox Hill and Manhattan Eye, Ear, and Throat Hospitals. He's also an assistant professor in the Department of Otolaryngology at the Zucker School of Medicine. Thanks also to our editor, Edward Lee, to our producer, Connor Pilkington, and our audio engineer, John Mullen. For more information about this program and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are also welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.